Alrighty, good morning, everyone. Welcome. It is my pleasure to introduce our lead faculty speaker today. It's, of course, Alex Kaplan, who graduated from medical school at McMaster and went on to do residency with us. He happened to be the first CARMS candidate that I interviewed ever in my role as program director. So clearly, I knew what I was doing right from the beginning. And anyway, Alex made good and went on to do his fellowship training at the National Eye Institute in the US. And he did several things there: uveitis, ocular immunology, and medical retina. So he's now on staff at Toronto Western Hospital and Kensington Eye Institute. And welcome, Alex, and also Seema and Chabot to present. Thank you.
Okay, thank you very much for the kind introduction. So we have three separate cases today. We have Seema, who's going to start off presenting a case, then we'll have Chabot, and then I have a case to present as well. So Seema, do you want to start off?
Okay, good morning, everyone. I'm just going to get set up. So my name is Seema. I'm one of the third-year residents here at U of T, and I'm going to share today a case that I saw at the beginning of the pandemic in the spring. So we received a referral for a 32-year-old female from her family doctor, referred for a visual field defect in her left eye that had been present for 6 weeks with new floaters. This was a medically complex individual who had a history of cystic fibrosis and had undergone a double lung transplant in 2014. She also had a history of cystic fibrosis-related diabetes. In the context of her lung transplant, she had had episodes of recurrent CMV viremia, which had presented with systemic malaise and fatigue, and always responded to oral valganciclovir. And of note, this had been quiescent for many years at the time that we met her. Unfortunately, her year had been complicated by some health conditions. She had had an admission for community-acquired pneumonia several months prior, as well as an admission for disseminated zoster. But at the time that we met her, she had returned essentially back to her baseline health. Her past ocular history and social history were unremarkable, and her medications had remained stable for quite some time. And her immunosuppressives included tacrolimus, mycophenolic acid, 5 milligrams of prednisone daily, and she was on Septra for PJP pneumonia prophylaxis. So on examination, her visual acuity was 20/40 in the right eye and 20/30 in the affected eye. Her intraocular pressures were normal, her pupil examination was normal, and the anterior segment was quiet in both eyes. Dilated fundus exam showed just an isolated dot plot hemorrhage in the right eye with a normal OCT of the macula, whereas the left eye showed a superior area of active perivascular granular retinitis with some trace overlying vitritis. This area of retinitis subtly extended inferiorly towards the superior arcades. And there was 4 quadrants of dot plot hemorrhages and mild venous dilation, suggesting a mild central retinal vein occlusion accompanied by some mild disc edema. Accordingly, on the OCT, we could see some inner retinal layers of disorganization of the inner retinal layers. Taking this all together in our patient, this seemed very clinically consistent with cytomegalovirus retinitis of the left eye. And I just want to take this moment to ask the audience and start a poll. Faced with this patient, which treatment would you consider? So we've got 4 options here. The first is just oral valganciclovir, intravitreal ganciclovir injection, a combination of the two of oral valganciclovir and intravitreal ganciclovir, or intravenous foscarnet treatment. So if everyone just wants to vote for one option.
All right, Seema, so I'm going to end the poll here and share the results.
Okay, so there's a little bit of a spread, which is not uncommon given there is no clear protocol in this situation, but it seems that most people would do a combination of oral valganciclovir and intravitreal ganciclovir. And that's what we did in this patient. So we started her on oral valganciclovir, 400 milligrams daily, which was renally adjusted for her chronic kidney failure, and started treatment with twice weekly intravitreal ganciclovir of 2 milligrams. And she responded quite well to this treatment over 4 months. As you can see from these pictures, there was quite a marked improvement from month 1 to month 2, and then a slower rate of resolution from month 2 to month 4 of treatment. At this point, because the rate of resolution had decreased, we started to be concerned for possible drug resistance and did consider at this point adding a third agent, adding intravitreal foscarnet. But the patient was quite resistant to the idea of adding a second intravitreal injection. And as well, approval for this was quite complicated given her history with her transplant medications. It was difficult to get approved. So we continued simply with the intravitreal ganciclovir and oral valganciclovir. She did develop some macular edema from the central retinal vein occlusion throughout the course, but we observed this and continued antiviral treatment. The OFTDOVS picture on the left shows her clinical outcome approximately 5.5 months after her diagnosis and after all treatment had been stopped for about 6 weeks. And you can see that the area of retinitis has atrophied, there is no vitritis, and she looks far more stable, and it has not extended to elsewhere in the retina. In this patient, we did not pursue an anterior chamber paracentesis for viral PCR because there was a high degree of clinical suspicion and the patient was quite resistant to this idea. However, her serum PCR, which had been chronically monitored given her previous history, remained undetectable throughout her disease course. Her treatment in total included over 25 injections of intravitreal ganciclovir over the 4 months, and she was maintained on the oral valganciclovir for 2.5 months. This may seem very long, but again, this patient had a slow clinical response, and given her chronic kidney disease, we were not always sure that there was adequate drug absorption. So in conjunction with her infectious disease physicians, we felt that it was safe to keep her on this. Her final visual acuity was 20/25 in the affected eye, and she has not had a recurrence to date. But of course, her treatment was quite challenging. As mentioned, there was slow improvement with concerns for resistance, and there was a significant burden of clinic visits for this immunocompromised patient during the height of the COVID pandemic. So what is CMV retinitis? It's a full thickness viral retinitis that presents with hemorrhage and necrosis throughout the retina, and it almost always presents in immunocompromised hosts. There was much higher prevalence and incidence of this condition several decades ago at the height of the HIV/AIDS pandemic. And we know that the risk to these individuals who are HIV positive is highest when CD4 count starts to drop below 50. Therefore, screening is recommended for all HIV positive individuals when their CD4 count reaches a threshold of about 100. There is, however, no similar risk threshold that has been identified in immunocompromised individuals who are non-HIV positive. CMV typically presents as one of 2 forms. The first is the indolent granular form that we see in our patient, which is restricted more typically to the periphery, compared to the more fulminant course of CMV retinitis that presents with widespread retinal necrosis and whitening and hemorrhages and has a propensity for early posterior pole involvement. In both of these cases, the goal of treatment is the same, which is to eradicate the active retinitis. And although there are different options, most physicians tend to elect for systemic treatment when there is either a concomitant systemic viremia, if there's bilateral involvement, or if the retinitis is restricted to the periphery. Whereas most would consider intravitreal or local injection if there is sight-threatening involvement of the optic disc and macula, if the patient's unable to tolerate systemic treatment, or if there's been a previous poor response to systemic treatment. And unfortunately, vision loss can occur through retinal atrophy and scarring, rhegmatogenous retinal detachments, formation of epiretinal membranes, and vascular occlusive events in the eye. There are a whole host of treatments that are available, but unfortunately, almost all of them have drawbacks. From the systemic perspective, ganciclovir is very rarely used because it's poorly tolerated. And now with the availability of valganciclovir, a prodrug with higher bioavailability, this has tended to become the first-line oral treatment. However, valganciclovir can be nephrotoxic, can induce myelosuppression, and can be quite expensive, costing about $25 a day for patients who do not have drug coverage. Other options include foscarnet and cidofovir, but these are available only as intravenous agents and so require hospitalization. Letermovir is emerging as a more commonly used agent, particularly for prophylaxis. And there are several more experimental or aggressive treatments such as leflunomide or CMV IgG infusion or even T-cell infusion that are progressively more experimental and reserved for the recalcitrant cases. From an intravitreal perspective, the most commonly used agent is ganciclovir, which is compounded by several of the hospital pharmacies. Foscarnet is also available, but requires special Health Canada access approval. And cidofovir has fallen out of favor since the 90s, as it was discovered to have a very narrow therapeutic window and becomes rapidly retinotoxic outside of that window. So CMV is part of the herpes viridae family. It is widely prevalent in almost every country where there's data. There's at least 50% seroprevalence, and it reaches approximately 90% when we look at all countries together. Transmission primarily occurs in the perinatal period vertically through intrauterine infection, genital secretions of the birth canal, or through breast milk. And in the postnatal period, it's transmitted through exchange of bodily fluids, including saliva, sperm, and blood. Primary infection can also happen in the cohort of people who undergo transplantation, whether solid organ or bone marrow and stem cell transplantation, especially when there is transplantation from a positive donor to a negative CMV negative recipient. The primary infection with CMV is typically very mild or asymptomatic and may present simply as a viral prodrome with malaise, fatigue, and muscle soreness. This initiates a very robust T-cell response, and at this point in immunocompetent individuals, the CMV viral particles are rapidly reduced. The latent DNA of the virus lives dormant or latent in the peripheral bone marrow, but has also been demonstrated in other organs, including the lungs, the ears, the brain, and the eye. And we've found latent CMV DNA in aqueous fluid. And this corresponds to the fact that we know CMV keratitis or anterior uveitis can present in immunocompetent individuals. So how does the CMV latent infection transform into an infectious retinitis? Well, in immunocompromised individuals, many studies have shown different molecular pathways by which the virus cleverly suppresses cytokine signaling and suppresses recruitment of the immune system to hematologically spread throughout the system and create an overwhelming infectious response. In most patients who present with CMV retinitis, it's either through a mechanism of reactivation or primary infection in a small group of people. Most commonly, these patients have reactivated disease. So in patients who are HIV positive, as mentioned, this happens when T cell function is decreased beyond a critical threshold, typically 50, CD4 count of 50. In patients who have hematologic disease or undergoing transplant, the mechanism of that chemotherapy eradicates the host immune response, thereby making them vulnerable. And in other patients who have systemic disease, such as cancer, or they have a medically induced immunosuppressed state, they also have reduced T cell function. Very rarely, there are reports in the literature of patients who have received, for example, periocular steroids and therefore have a state of local immunosuppression, whereby they may also have CMV retinitis. And as mentioned, in our transplant patients, particularly those where there is mismatch from a seropositive donor to a seronegative recipient, there is a high risk of primary infection in these already immunosuppressed patients. And despite prophylactic treatment, CMV viremia often recurs. So of course, this is a relatively rare disease in a small population. So we have very little data that accurately compares the cohort of patients who experience CMV retinitis in HIV positive patients versus non-HIV positive patients. So it's difficult to know whether this is a different disease amongst these groups. However, we do know that the incidence is decreasing in the HIV positive population due to advances in antiretroviral therapy. And we also know that in these patients with newly diagnosed HIV who are started on effective antiretroviral therapy, when they develop CMV retinitis, they may be at a higher risk of immune reconstitution uveitis, and therefore may get worse with treatment initially and should be monitored closely. Overall, however, it appears that these groups are more similar than different. They have similar presenting and outcome visual acuities, their rate of recurrence is similar, and the risk of adverse events such as posterior pole involvement or retinal detachment is unfortunately similar as well. However, the non-HIV positive population poses a unique treatment challenge. In these patients, lifelong immunosuppression is often required. So unlike in the HIV positive group, where reconstitution of the immune system represents kind of an end goal of treatment, this is not the case in this non-HIV positive population. As a result, it's not only challenging to treat them for CMV retinitis in the acute phase, but ongoing prophylactic maintenance treatment may also be limited. As we discussed, many of the agents that we have available for treatment and maintenance have side effects or adverse events that make them intolerable long-term, such as a nephrotoxicity or drug-induced neutropenia. Therefore, it can be very, very challenging to find a long-term way forward for these patients. And they may actually require monitoring or change of the immunosuppressive regimen, which is no small feat. And with the requirement for long-term drug therapy comes a high risk of drug resistance and potential for subtherapeutic drug activity as they develop toxicity. So in conclusion, cytomegalovirus is a highly prevalent virus around us, both around the world and in our local communities. And with the ever-expanding indication for chronic immunosuppression in oncology, in rheumatologic disease and beyond, it's highly likely that CMV retinitis incidence may increase in this population and may present itself to your local eye clinic or emergency department. Early recognition of CMV retinitis and a high suspicion in these patients allows for early treatment and diagnosis and may mitigate adverse outcomes. And we recommend early collaboration with uveitis specialists, with your internal medicine and infectious disease colleagues as well, to help manage these difficult patients. So with that in mind, I'd just like to thank Dr. Kaplan for his help with this case, and to Dr. Bakshi, Dr. Giovadoni, and the retina team at St. Michael's that came together to help treat this patient in a very difficult time in providing eye care. Thank you.
Great job, Seema. I think perhaps in the interest of time, I think we'll maybe move on to the next case and then hold all the questions at the end, but please feel free to type any questions into the chat box so we can address them at the end of the presentation.
Seema, do you want to just hit end share there? There you go. So Shaba, you should be able to share your screen. Perfect. Thank you.
Good morning, everyone. This is Shabo and PGY4 residents. And I would like to thank Dr. Alex Kaplan for having me to present this interesting case. So the case today, it's a 38-year-old man from Afghanistan. He has been in Canada since 1998. His concern about his vision is that he sees wavy line and blind spot in both eyes. Started 3 years ago and has been gradually changed over the last 3 years. He does not have any significant ocular history or past medical history. He's not a drinker, not a smoker. He's not on any medication or eye drops. On examination, his visual acuity is not bad, 20/25 in the right eye and 20/20 in the left. The IOP is normal, pupil, no REPD. Anterior segment is pretty normal. And then, but we notice some trace vitreous cells bilaterally. So in summary, it's a healthy 38-year-old man from Afghanistan with minimal to moderate visual impairment, and then this is the fundus appearance. We can see bilaterally on the posterior pole around the optic disc and macular area, there's multiple placoid lesion with variable pigmentation and atrophy, and the lesion does look flat, and it's not rather than a space occupying nodule or mass, and then it's subretina, involving RPE, maybe inner choroid or outer retina. And on the autofluorescence photo, we can see multiple hypo-autofluorescence area corresponding to the lesion that we see on the color fundus photo. And then we don't see any hyper-autofluorescence, which may represent inflammation. So the overall, it does look chronic. So let's talk about the differential diagnosis of placoid chorioretinopathy. And I break it down into two categories. There is non-infectious category, mostly Raynaud syndrome, and including serpiginous choroidopathy, acute posterior multifocal placoid pigment epitheliopathy, the so-called MP, and something in between, the andpyginous chorioretinopathy, multifocal choroiditis. These are all within the spectrum of Raynaud syndrome. And then there are sarcoidosis, lymphoma, more like infiltrated process. And then there's an infectious subcategory, including TB, syphilis, and toxoplasmosis. So while this is a shorter version of differential diagnosis for placoid chorioretinopathy. And so what is the most likely diagnosis in our case? I will make it a bit easier. I will break it down further. So I'd like to introduce a few Raynaud syndrome, and then I would like to have the audience be familiar with these patterns. So this is a little bit of pattern recognition training. So serpiginous choroidopathy, it's a Raynaud syndrome, very aggressive and very difficult to treat Raynaud syndrome. The lesion often started from near the optic disc area, and the lesion is flat. And when it's new, it's yellowish and white. And then, but when the disease subsides, it comes with severe scarring, pigmentation, and atrophy. It runs a recurrent, relapsing, and progressive course. And interestingly, it started at one point, and then it spread literally like a wildfire. The reactivation, the inflame, the flame is always at the junction of old lesion and normal retina. And then over time, it gives a serpiginous means snake, but I call it amoeba-like appearance. So it's spread like a map. And it's a very aggressive disease, and then it often needs a steroid and immunosuppressant treatment. Could our patient be a serpiginous choroidopathy? So this is another case of serpiginous choroidopathy. You can see this amoeba-like appearance, a lesion occupy entire macula. You can imagine how devastating it is to the vision of our patient. And then this is another case of serpiginous choroidopathy. This is the patient that I saw when I was back in China. So it's a bilateral disease, but it can be in different stages. And you can see the right eye, it's a very active disease. And on the left side, it's a chronic looking disease engulfing the entire posterior pole. And the patient has only hand motion vision. Okay. And then, or could our patient be another entity in the Raynaud syndrome called MP, acute posterior multifocal placoid pigment epitheliopathy? So the characteristics of MP is pretty much summarized in the name. So it's acute disease, and the acute onset often followed by the onset often follow the viral prodrome. It's posterior, it's near the optic disc and macula area. It's multifocal, creamy yellow, deeply placoid lesion. Described in the book, it says at the RPE level, but actually it's often involved inner choroid and outer retina. And unlike the serpiginous, MP often runs a self-limited course, and the visual prognosis is a bit better, and the visual symptom often improve or resolve within several weeks, and it produces less scarring and atrophy. Currently, there's no consensus on treatment, but we need to, I need to emphasize that this disease sometimes has CNS involvement. Patient can have CNS vasculitis. If an NP patient with headache or encephalopathy, that will require CNS investigation. Could our patient be NP? All right, so this is another NP patient with deep multiple creamy deep lesion at the RPE level with characteristic early hypofluorescence at the early stage of IVFA, and then late staining and leakage. This is another NP from photo from the internet. So NP and serpiginous are within the spectrum of Rydolph syndrome, and there are a lot of gray zone between them, and a disease, an individual case can be sitting in the middle. So eventually, people describe the Rydolph syndrome with overlapping characteristic from NP and serpiginous disease. They name it enpiginous chorioretinopathy. There's something sitting in the gray zone in between. So basically, so this is posterior multiple. It's like NP. It's multiple lesion, not a one single lesion spreading, but every single lesion has potential to develop a serpiginoid pattern of growing with reactivation of the disease happening at the junction between old lesion and normal retina. Could this be our cases? So this is another enpiginous chorioretinopathy. We can see that multiple pigmented amoeba-like lesion in the macula and optic disc area. And in the photos on the left-hand side, there's some mild vitritis as well. So after reviewing the pattern of serpiginous, NP, and enpiginous, so which one do you think most closely resemble our cases? Okay, I can pick any audience in this webinar format, so I'll go ahead. So we believe this is enpiginous chorioretinopathy, and it looks inactive because some patient can show progressive changes over time. So we discuss at this point, while in the literature, there's no consensus on the treatment in the inactive stage of this disease, but we offer and discuss the treatment options, and the patient decided not to treat for now. And we started workup, including check 6-way, syphilis, AMA, ANCA. These are all negative. We also order quantiferin gold and serum ACE to rule out TB and sequelae. In 1 month follow-up, so we first saw the patient in April, and then in 1 month follow-up, we noticed something changed. By the way, the patient remained, the symptom remains stable. He didn't notice any new changes. But on the autofluorescence photo, we noticed there's an area adjacent to a large atrophic scar that shows hyper autofluorescence. And then we worry that this could be a sign of inflammation reactivation. Meanwhile, his quantiferin gold returned positive. And it's not just mildly or borderline positive, it's highly positive. And then, more interestingly, his ACE level is also high. Then what do we do next? This is the IVFA at the time. It's done elsewhere. I apologize for the poor quality, but you can appreciate the hyper fluorescence at the border of this atrophic scar near the macula. So this corresponding to a suspicious area of reactivation. And then we asked our colleague in respiratory medicine for help. In summary, they believe this patient most likely have TB. So his serum ACE is neither sensitive nor specific for sacroid, and he doesn't have any extrapulmonary sacroid changes. And then he was seen in TB clinic and started 4-drug therapy for 6 months' time. Meanwhile, we started oral prednisone treatment with tapering course. We did a CT chest and it finds some calcified granuloma in the left upper lobe and lymph node, and suggesting an old infectious lesion such as tuberculosis rather than sacroid. With the treatment, he responded to a steroid very quickly. So within a month, so we started treatment in May, and then in June's follow-up, we noticed the hyperautofluorescence area is subsiding. So it's becoming less intense. In July, and it's pretty much looks pretty much normal. So in September, there's no sign of activation at all. So at this point, our patient finished his steroid tapering. He's still on anti-TB treatment, and his symptom remain stable. Tubercular serpiginous like choroiditis is one of many manifestations of ocular TB. So the lesion is yellowish when it's new, but over time it turns into pigmented scar, and each single lesion can show serpiginoid enlargement over time. In endemic area such as India, it's a more common cause of empygenous choroiditis. It's more common than the idiopathic form of empygenous choroiditis. And in a series, this is a series from India of 141 cases, and it describes some characteristic of this disease. It's often bilateral, and it's almost always multifocal, and it often comes with vitreous inflammations, and it's non-contiguous to the optic disc and mostly. And then the study shows with anti-TB treatment, and the recurrent rate is much reduced compared to a patient treated with steroid alone. So TB serpiginous-like choroiditis, it's very, very similar to the idiopathic form of empygenous chorioretinitis. So on this photo, which one do you think is it's caused by TB? Is it the patient? Is it a photo on the left-hand side, which shows multiple and amoeba-like lesion, but it's not contiguous to the optic disc? However, it doesn't show any vitritis. On the right-hand side, it shows vitritis, but it's contiguous to the optic nerve and spreading more like a serpiginous choroiditis. Which one? Actually, they are both. They are both TB and serpiginous-like choroiditis. So actually, many people believe that the idiopathic form of empygenous disease versus TB form of serpiginous like chorioretinitis, they share some common final pathway, and the TB serpiginous like chorioretinitis is actually represent a process of hypersensitivity to TB infection. So in summary, we review the pattern of serpiginous choroiditis, MP, and empygenous choroiditis. The take-home message is that whenever you see any of these changes, any of these patterns, TB, you need to rule out TB in any of these. This is the last slides of my presentation. Thank you very much.
Okay, great job, Xiaobo. So I think Fariba Nazemi, did you have a question? I think it showed that you raised a hand, but I'm not sure if you pressed it accidentally.
Okay, maybe not. So sorry, Alex, that's my fault, I guess. For the audience, if there are questions, feel free to use the chat box as well, and we'll try to get to those at the end. Shabo, great job. If you could just hit end share on yours, so Alex will be able to load up his slides. Thank you.
Okay, so moving on. So, okay, so moving on to mystery case number 3. I'd just like to, so I just wanted to just introduce myself again. So my name is Alex Kaplan. I practice at Toronto Western Hospital in Kensington, at the Kensington Clinic. So this is a interesting case. I hope this morning has been educational for everybody. This is a case that actually presented to me during fellowship, but I think it has many interesting learning points and often not something that we have the opportunity to discuss in this forum. So, okay, so let's move on. So I'd like to start off with just a quick poll of the audience. So we have Louis Braille, who is the inventor of the Braille reading system. We have J.S. Bach, who is a German composer and musician. And we have James Thurber, who is an American American playwright and cartoonist and author. And these 3 individuals, what eye disease do you think they all have in common? We'll let that poll run.
I'm curious to know the answer, so we'll let this poll run for a few more seconds, but I'm really curious to know what this is, Alex.
Okay.
So nobody thinks it's keratoconus, but otherwise there's a nice split.
Okay, so we can, I guess, end the poll there. Okay, so it looks like it's almost a equal split between JA and sympathetic ophthalmia. This is a uveitis morning, so looks like most people are clued into that, but you'll have to stay tuned to see.
wasn't described at the time.
Okay, yeah, that could be true. That could be true. Okay, so you'll have to stay tuned to see the answer. So let's move on to the case. So the story begins in November 2016. We have a 62-year-old white male who was complaining of flashes and floaters in the left eye. He was examined by an ophthalmologist at that time that noted a retinal tear in the left eye and treated it with laser retinopexy. Fast forward to December, between December and July of 2016 and 2017, the patient noticed a progressive visual field defect. He was diagnosed with a retinal detachment, and he went on to have a pars plana vitrectomy. He then redetached in January 2017. He went for another vitrectomy, and they ended up placing silicone oil. It was a very complex surgical repair. Then in 2018, the vision unfortunately declined to no light perception, and there was no more surgery and procedures that were done to this eye at that time. Now, in between this whole process, in September 2017, he was noticing that he had gradually worsening vision in his right eye, the non-operated eye. His symptoms initially were mild. Vitreous cell was noted in December 2017. And at that time, the photos that were taken, you could see that there were multiple deep hypopigmented choroidal lesions that were present in the right eye, as well as optic nerve edema. The IVFA showed early hypofluorescence over those lesions, followed by late staining, as well as a hot disc. So the recommendations at that time in December, they did an infectious inflammatory workup, which was unremarkable. He was diagnosed with multifocal choroiditis or possible sympathetic ophthalmia, given what was happening in his left eye, but they were also considering a primary intraocular lymphoma as a possibility over here, given this patient's age. He was started on prednisone high dose as well as Cellcept as a bridging agent, 1,000 milligrams twice daily with slow taper of oral prednisone. Now, between January and July with tapering prednisone, his uveitis activity increased at around 20 milligrams of prednisone. So at that point, Cellcept was increased to 1,500 milligrams twice daily. And they also added methotrexate 15 milligrams every 1 week. Anti-TNFs were never initiated at that time or later due to concern over the possibility of a neoplastic cause. He did receive a surgical consult to consider a biopsy. They were really entertaining this possibility of a neoplastic cause, but there was a lot of hesitancy due to the protracted course that he had in his left eye. They recommended not pursuing that at that time. So this is the photograph fast forwarding to August. You can see that there are many more of these choroidal hypopigmented lesions that are clustered in the mid-periphery. At this time, the visual acuity was 20/40. And unfortunately, the patient was lost to follow-up. There were other medical issues that were going on. There were many appointments over the last few years, and he did not follow up with his medical providers. It was really in January 2019 that he presented to the clinic where we assessed him. He had floaters, he had constricted visual field, and he had tinnitus. The visual acuity was 20/80 in the right eye and still no light perception in the left eye. The intraocular pressure was 17 in the right and 6 in the left, and there was a reverse relative afferent pupillary defect. Medications at that time were mycophenolate mofetil or Cellcept 1,500 milligrams twice daily. Methotrexate had been increased to 20 milligrams once a week. He was on folic acid, vitamin D, and ranitidine as needed. He was off prednisone and off all drops for approximately 1 month when we had assessed him. Slit lamp examination had normal lids, conjunctiva, and cornea. The anterior chamber had 1+ cell. The iris was within normal limits, and there was some cataract, steroid-related cataract in the right eye. The left eye was stysical with some band keratopathy, and you could see some silicone oil in the anterior chamber. So this is the photograph at the time we assessed him. You could see that there is a worsening of these choroidal lesions, even from all the photographs that we had obtained in the past. And you can see some of these lesions are even starting to become confluent. They are more localized to the mid-periphery. And you can see that there's still some optic nerve swelling. You can see some vitreous debris here as well too. There was no view in the left eye. This is a photograph video of the OCT of the right eye. You can see multiple subretinal and choroidal inflammatory lesions, as well as massive cystoid macular edema. And these lesions are between sub-RPE, subretinal lesions in their location. This is a autofluorescence photograph that shows hypoautofluorescence over those choroidal lesions. And you can see many of them have this hyperfluorescent ring around them, which is quite characteristic. This is an IVFA that shows early hypofluorescence and late staining of all of the lesions. And you can see also there's this hypofluorescent ring as the staining starts to appear in the center of the lesion. Now, we don't get to look at a lot of these photos, but they are very helpful. Indocyanine green angiography. This is a angiogram that is focused more on the choroidal circulation. And you can see usually the photos are taken over quite a long period of time, 30 minutes for the late frames. And you can see in the mid kind of frames of the photograph of 3 minutes, there's many hypocyanescent lesions. And in the later frames of these photographs, a lot of those hypocyanescent lesions leave, and you can see some remain. Interestingly, some even on the vasculature, which can be indicative of granulomatous disease. This is a 30-2 visual field showing severe visual field constriction in his only seeing eye. So investigations at that time, infectious inflammatory workup was repeated, which was unremarkable. Genetic testing was done, which was positive for HLA-DR4. So in summary, we have a 64-year-old white male with right eye panuveitis, cystoid macular edema, multiple yellow chorioretinal lesions clustered in the mid-equatorial region of the fundus. Symptoms began following a complicated surgical course in the left eye. So what are the recommendations? So the presumptive diagnosis was sympathetic ophthalmia. We admitted him for urgent high-dose pulse steroids for 3 days and transitioned him to 60 milligrams oral prednisone. We started him on an anti-TNF infliximab at 5 milligrams per kilogram. Infusions, we discontinued methotrexate because he was not tolerating it and he was already on antimetabolites, another antimetabolite. And we made a referral to an otologist to evaluate his tinnitus. So this is pre-treatment escalation in January, and this is after high-dose oral prednisone. So you could see that the cystoid macular edema had resolved. Unfortunately, his vision improved only marginally due to the protracted course of his disease. So let's speak about sympathetic ophthalmia. So yes, this is the condition that is common to all three of these individuals. We don't have time during this presentation to speak about this, but it is an interesting history tidbit. So I encourage everybody to read around it and look it up. So sympathetic ophthalmia from a historical perspective. So we know that this disease has been described since ancient times. Hippocrates even referred to it. But it was really until the 1800s that William Mackenzie coined the term, and he had the first clinical descriptions in 6 patients. And then following that, the histological description was followed by Ernest Fuchs in 1905. And in William Mackenzie's book, The Practical Treatise of the Treatment of Eye Diseases, he went through a lot of these descriptions. I haven't looked at the Toronto Western Library, but I have a feeling that this book is probably in the library over there because it is a very historically important book. And in that book, it describes the treatment with opium, mercury, and leeches. So, and if you go to Amazon, for just $27.95, you can buy this book, and it's actually been selected by a group of scholars as being culturally important. So when you look through the book, it describes the treatment. So it says that, it just describes a patient that had a screwdriver injury penetrating open globe. Leeches were applied twice daily to the eyelids, opium at bedtime. So really, a lot has changed in the treatment of sympathetic ophthalmia since the 1800s. They did comment on the fact that very seldom has he seen an eye recover from this disease. So that kind of goes to show the aggressiveness of patients that have sympathetic ophthalmia. And the treatment, rest, internal use of mercury and belladonna. So just kind of interesting to read about. So let's define sympathetic ophthalmia a little bit more. So this is a bilateral asymmetric granulomatous uveitis. It often follows accidental or surgical trauma in one eye. We call that the exciting eye. And then that leads to uveitis in the unaffected eye, the sympathizing eye. Severity can vary and can present in various different ways, whether it's anterior, intermediate, posterior, or pan-uveitis. And this is rare. It constitutes 1 to 2% of all uveitis cases. Timing, classically, this was taught that 80% of sympathetic ophthalmia occurs in less than 3 months and 90% in less than 1 year. There are sympathetic ophthalmia reports early as 2 weeks and as delayed as 50 years. So it's important to always ask about surgical history or trauma in patients that we see with uveitis. And cases from intraocular surgery tend to have more of a delayed presentation. So there's the trauma cohort of patients, and there's the group of patients that have intraocular surgery, and those ones tend to be more delayed. So it's always important to keep that in the back of your mind. So what's the incidence? So prior to the 1950s, trauma really was the major source of sympathetic ophthalmia. It accounted for 2% of open globe injuries. There were even reports during the US Civil War. There's a lot of data that is collected through the US military because they track a lot of these patients go to military hospitals, and a lot of these reports are tracked through those databases, but 16% during the US Civil War. And from various retrospective studies with penetrating trauma, it's approximately 0.2 to 0.5%, and 0.01% after intraocular surgery. And from some prospective studies in Ireland, they quoted it at 0.03 out of 100,000 surgical cases for sympathetic ophthalmia. Now, in particular, the surgical procedure that was identified was vitrectomy. Now, you know, this statistic is also present in the American Academy manuals. It seems highly less common than what is quoted over here, 1 in 800. I think, you know, vitrectomy, how we perform vitrectomy has changed a lot since the 90s. And we certainly don't see sympathetic ophthalmia, I think, at that rate, just given the amount of vitrectomies that happen, you know, in such a big city like Toronto. I'm not sure if there's any surgical retina colleagues that are logged on that can maybe speak about how vitrectomy has changed since then, but I think that accounts for that decrease in that cohort. So modern day sympathetic ophthalmia. So we know overall rates are declining, and we know that visual outcomes are favorable, and that's changed quite a lot since William Mackenzie's days. 50% of patients will maintain a visual acuity of 20/40 or better. But really the biggest predictor of this is early initiation of immunomodulatory therapy was the most predictive. The US military had no reported cases of sympathetic ophthalmia in World War II, the Korean War, the Vietnam War, which they documented 467 open globe injuries. And even in the US Operation Iraqi Freedom, which showed no rates of sympathetic ophthalmia, there were high rates of early enucleation that probably accounted to this. But there was, you know, probably some selection bias with this because average follow-up was 200 days after the injury. So if people had a delayed presentation of sympathetic ophthalmia, it might not have been included in these statistics. So I won't belabor this chart because we've spoken about this, a lot of these points already, but I do want to just highlight the risk reduction over here in the historical perspective, which was predominantly trauma-related sympathetic ophthalmia. You know, recommendation to do enucleation less than 2 weeks to prevent sympathetic ophthalmia is, as classically taught, and is obviously still the recommendation. Currently, we know that we're seeing more cases of sympathetic ophthalmia following surgical incidents. So once someone has developed sympathetic ophthalmia, there is no benefit, or definitely questionable benefit is not recommended to do enucleation once the immune system is triggered to attack these uveal or ocular antigens, the damage is done. So enucleation is not beneficial at that point. So let's speak about clinical findings. So as I'd mentioned before, this can present as an anterior, intermediate, posterior panuveitis. Typically, these are posterior findings. The typical posterior findings are those Dalen-Fuchs nodules, which is a common exam question for the residents. So these are those yellow, white choroidal lesions that tend to start in the mid-equatorial retina. So if you can ingrain that photograph of this case in your mind, that might help that stick. And these nodules tend to become more confluent over time, especially in advanced cases. But it is not pathognomonic. It's only reported in 30% of sympathetic ophthalmia cases. You don't need to have those lesions to have sympathetic ophthalmia. Other clinical findings that can be associated is exudative retinal detachment, cystoid macular edema, choroidal neovascular membrane, or optic nerve atrophy. So let's look at just a bit more information on sympathetic ophthalmia on imaging. So those Dalen-Fuchs nodules, as I mentioned, it's not pathognomonic. Active lesions tend to have that early hypofluorescence with late staining. And once the lesions become more inactive, they turn into atrophy, which would just be seen as a window defect on IVFA. And if there is an exudative retinal detachment present, the fluorescein would pool in those areas of exudation. And then for the indocyanine green angiography, so there tends to be multiple hypocyanescent spots that are best visualized in the mid phases of the angiogram. So at 30 minutes, some of those lesions can disappear. If they do disappear, those tend to be the lesions that are more active. If they persist, those tend to be the more inactive and atrophic areas. On OCT and B-scan, choroidal thickening can be seen. So what about the histological features of sympathetic ophthalmia? So as I said before, this was first described by Fuchs in 1905. This is the histological slide that shows Dalen-Fuchs nodules. We tend to see a diffusely thickened choroid with a sea of lymphocytes. And the inflammatory characteristics in particular are granulomatous, non-necrotizing, and it tends to be predominantly lymphocytic. It also tends to spare the choriocapillaris and retina. This point is debated because there's probably some selection bias of when we're receiving this tissue, because if we tend to enucleate eyes, with sympathetic ophthalmia, if that is done earlier, let's say, or if we get tissue from sympathetic ophthalmia patients, it tends to be earlier in the course. And perhaps that is why the choriocapillaris is spared in those cases versus something like VKH. Maybe that tissue that we're obtaining is later in the disease course, which is why it's not spared. So why and how does sympathetic ophthalmia happen? Well, the truth is that no one really knows, but there is a hypothesis that it kind of is this perfect storm analogy. So you have penetrated ocular tissue from whatever the cause, whether it's surgical or traumatic, that releases uveal antigens, and those uveal antigens drain back through the lymphatic drainage. And then there needs to be some kind of pro-inflammatory infectious agent at that time, something to trigger the immune system. It's one thing to notice the antigens, but it's another thing to have the immune system activated and elevated when these antigens are being processed and released. We think that skin flora is associated with this in some capacity. This model is supported in animals. So we know that T lymphocyte response to previously sequestered, so if you have previously sequestered self-antigens in the eye, we know that the eye is an immune privileged site, and there is T lymphocyte responses in animal models. And those antigens in particular are S antigen, melanin associated antigens, and antigens from the RPE and choroid. We know that in the sympathizing eye, there tends to be more of a CD8 positive T cell response, and the exciting eye, there tends to be more of a CD4 positive response. So how do we treat it? Well, there's the surgical approach, which is more the preventative aspect of this. So in cases of trauma, we try to salvage every eye possible with meticulous and prompt closure of penetrating injuries. And we try, in cases where there's severe ocular trauma with no visual function, we try to organize an enucleation less than 2 weeks at the time after the time of injury. Evisceration due to cosmetic reasons is done more commonly these days. It has been reported that sympathetic ophthalmia can happen even after evisceration. So I think this is something to be aware about, and it's important to counsel patients that are going for evisceration that this is a possibility, although this is not common. And even if sympathetic ophthalmia does develop, regardless of the vision, enucleation is not recommended because it's shown to have no proven benefit. So in those cases, surgical treatment is not recommended. So what about the medical treatment? So now you have a patient that has sympathetic ophthalmia or something that is suspicious for sympathetic ophthalmia. The treatment is predominantly medical. It includes high dose systemic corticosteroids at 1 to 1.5 milligrams per kilogram. And then transitioning those patients to steroid-sparing agents such as Imuran, or azathioprine, methotrexate, and mycophenolate mofetil. If that's not able to hold them, escalating therapy to cyclosporin or an anti-TNF agent, and in very severe recalcitrant cases, rituximab or alkylating agents. Local steroids has been discussed as far as patients, if they cannot tolerate systemics, sympathetic ophthalmia has been treated locally with some success. And today, with prompt treatment, visual prognosis can be good, as I had mentioned before, 50%, 20/40, 25% though may still become legally blind in the sympathizing eye. So it is important to recognize this problem early to help have a good visual outcome with these patients. So in conclusion, it's very important to ask every uveitis patient about a history of trauma or surgery, and in particular, pars plana vitrectomy. In patients that have undergo globe repair or enucleation in the setting of trauma, this should be performed less than 2 weeks. And sympathetic ophthalmia has changed a lot in the last 150 years, and outcomes have improved dramatically with the early initiation of immunomodulatory therapy. And with that, I'd like to thank you for the opportunity to chat. I wasn't sure how we were going to do on timing, but this is my email if you had any questions to ask, or maybe we can open the poll at this point in time.
Fantastic talks from all of you. Thank you very much. And Alex, I'm glad to see you love my ophthalmic history as much as I do. We were at 8:32, so we're pretty much out of time. I would just, if there's any last minute questions, please use the chat box and we will answer them. I just want to remind you that Amandeep put up the evaluation link in the chat box. If you simply click at the bottom of your screen on the chat and make sure you click on the Google document before we sign off the meeting, you can access the evaluation form that way. I think you've answered almost every question as part of your talk, Alex, since the chat box is not lighting up. Seema, I do have a question for you. Do they try to match the donor's CMV positivity with the transplanted seropositivity to avoid CMV retinitis?
That's a good question and something I couldn't find a conclusive answer on. From what I could see, I think no, it's screened for and treatment is initiated, but just with the limited availability of transplant. I think if it were possible, absolutely, but it's not something that, I don't think there's enough transplant donor available essentially to be that specific. But I do know that for blood donation, that's something that is routinely screened for, and then they stratify in patients who are very at risk, for example, pregnant patients or patients who've had a history, they will give there's regular blood donation, which has been shown to be negative CMV viral particles. And then they have an extra kind of layer of screening where they go through antibodies of the donor, et cetera. And then they will stratify that way. So there is more stratification for blood donation, but in the world of transplant, I think it's just not possible to do complete donor matching.
And then Dr. Ostreicher, you had some comments.
Yes, about the enucleation issue. I think most oculoplastic surgeons are not eager to rush into enucleation early as a preventative measure because, the incidence after trauma, after meticulous closure is probably very low. And as Alex mentioned, the treatments are usually quite effective. If pushed, I would quote to a patient the risk of sympathetic after a repaired ruptured globe as about 1 in 1,000, and up to 90% of those might be treatable. So the risk of blindness would be 1 in 10,000. I'd emphasize that those are guesses. And the problem, of course, is a lot of patients in the broader world don't understand statistics. So the idea of the other eye becoming affected sometimes scares people into pushing themselves forward for an enucleation. Second point is that I would, if you're doing this as a preventative measure, I would never do an evisceration. That probably would increase the risk, not decrease it. And the third point is that against enucleating early is that occasionally the injured eye, the primary inciting eye, ends up with a better vision.
Interesting. Yeah, very, very good point. So, but you're saying in cases though that you're not able to close the globe, NLP vision, the injury was 5-6 days ago, and then they just presented to the emergency department. In that situation, you wouldn't eviscerate, you would just enucleate, is what you're saying.
If you're going to do anything at all, yes, I would present the odds to the patient and document it very carefully and do what the patient wanted. I
see. Okay, great. Thank you. Great to have an oculoplastics specialist logged into the call. Thank you.
I think Jamie's probably done 1 or 2 of these cases in his career, so thank you for sharing your expertise.
Have you seen like how many cases of sympathetic ophthalmia over the course of your career have you been involved in and seen?
I think 2.
2. Okay.
Your statistic about 1% of all uveitis cases again sounds way overblown.
Yeah, I think also how they define it. Like this case was, a slam dunk, had every clinical finding that is presented in the book. But I think if a patient presents, with a more mild case of anterior uveitis, I think it was just a very broad inclusion criteria, perhaps.
Yeah.
Okay, and Alex, we have a question here from the chat. We'll make this the last question. Juliet asks, have you observed immune recovery uveitis amongst your patients on treatment for CMV retinitis? Do you want to just comment on that?
I have one patient currently that I'm dealing with that, I'm wondering, is it more immune recovery versus just, activity from a CMV perspective. I think PCR can be helpful in differentiating some of these cases. Once you start treatment and once their CD4 counts increase, retapping these patients, especially if you tap them at the time of presentation and then initiate treatment, and then you kind of have a bit of a benchmark, although it's not as much for diagnosis as it can be helpful in the HIV population when you're trying to work out if there is immune recovery later on. Often patients don't want AC taps, and it can be challenging to have that happen for every case, but immune recovery is something that you need to be aware about, and also just speaking with your infectious disease specialist to help tease that out a little bit more can be helpful, because if these patients do require steroids, and they are HIV positive or have other immunosuppressed states, you need to work with them as far as prednisone initiation or working out the best treatment to handle that. So it's tricky. I don't know. I think I saw. I don't know if you have any comments, Dr. Bakshi, on immune recovery in particular. Have you?
Yeah, I rarely observed that with these patients. I really can't think of the last one. I think it's far more common in the patients who are maybe initiating heart for the first time, but very, very rare.
Okay.
Also, I just wanted to comment for that case. The one thing that we really were missing there, because the course was so long, was quantitative CMV PCR. The patient had a panic disorder and could not tolerate AC tap, and it took a lot of, let's say, a very slow process to even get the intravitreal injections done. But really, that would have probably helped us in the course of that treatment to be able to really see why she was taking so long to respond.
All right. Once again, thank you, everyone. There were a couple more questions, but I think in the interest of time, we're gonna bid farewell. It was a fantastic series of presentations this morning. Thank you very much for all your efforts. Great work.
Great job,
again, don't forget to click on the link in the chat box. Last chance. Okay. Bye.
Great job.
Great. Thanks, everyone.
Stay safe.
Bye.